I'm joined by Dr. Anna Glezer. Dr. Glezer is a reproductive and integrative psychiatrist who trained at Harvard and UCSF and is now in private practice in California. She's board certified in psychiatry, a past president of the Northern California Psychiatric Society, and a volunteer associate clinical professor at UCSF. Her clinic, Women's Wellness Psychiatry, provides mental health care to women across the reproductive lifespan, from premenstrual symptoms to pregnancy, postpartum, and perimenopause, using an integrative and holistic, trauma-informed, whole-person approach. She's also passionate about teaching and educating both patients and clinicians, and has a podcast, Women's Wellness Psychiatry, an online fellowship course for clinicians, and an educational blog. So today we're going to be talking about Dr. Glezer's work as an integrative and reproductive psychiatrist, what sleep has to do with all of this, and her new fellowship program. So let's jump in. All right. Well, thanks, Dr. Glezer, for joining me today. I'm really excited to have this conversation with you about integrative and reproductive psychiatry. And so I thought it would be a good place to start just by understanding, what is integrative psychiatry? We're both integrative psychiatrists, and many people don't actually quite know what that is. It's a relatively new-ish field. So what is integrative psychiatry? And then what is reproductive psychiatry, which is your other specialty?
Thank you for asking those questions. And thank you so much for having me today. I'm really excited to be here and to be talking with your viewers about these really important topics. So let's start with reproductive and integrative psychiatry. The reproductive piece really means working with women across the reproductive lifespan. So it could be premenstrual symptoms. It could be challenging fertility journeys, pregnancy, postpartum, perimenopausal transitions, really whenever there's a hormonal component to mental health symptoms, which is a very significant component of a woman's lifetime, her reproductive years. So that's what reproductive psychiatry covers. The integrative psychiatry piece is an approach, and it is something I was actually just clarifying for one of my supervisees, the difference between, I think there's sometimes a confusion between integrated and integrative psychiatry. And so integrated psychiatry is when you have mental health treaters embedded in, for example, a primary care office or another medical kind of situation, whereas integrative psychiatry, which is what you and I do, is more of an approach. It's really looking at the person from a whole person, multidimensional kind of perspective for both the cause, the etiology of their mental health symptoms, as well as the treatment planning portion. So it goes beyond kind of conventional medicine and just psychopharmacology, and it includes all of the other different treatment modalities that could be really useful to help an individual feel better from a mental health perspective. I like to think about it as promoting mental health and wellness as opposed to focusing on mental illness and disease. And so it's, in addition to, of course, some of the conventional treatments, prescribing medication, for example, it can also include a lot of work with nutraceuticals, supplements, and botanicals that can be useful for a wide variety of mental health symptoms. It's also looking at the role of psychotherapy, whether it's different kinds of psychotherapy, individual therapy, group support, mindfulness approaches, spirituality and the role of our spirituality in our mental health, and other kinds of treatment options, ecotherapy, nutritional medicine, given the gut-brain connection, physical activity, complementary treatment options like acupuncture, putting all of these different things together in a comprehensive kind of treatment approach that goes beyond just prescribing medication, but certainly does include prescribing medication because that can be a really important component of the treatment plan. And then it looks at, what is causing these mental health symptoms from more than just, a biological, what are the malfunctioning receptors approach, but, what are all of the different psychosocial and other variables that are contributing to this mental unease, and how do we help it feel better from this holistic approach?
So much great information there that you just shared. And I think, so there's a few important things to note. So the difference between integrative and integrated care. So I think that's good. So, for physicians who are referring their patients for this more holistic integrative approach, it's important to just get that wording right when you're doing a search. And then same for patients when they're looking for an integrative clinician, whether it's an integrative psychiatrist or primary care doctor, that word integrated versus integrative does make a big difference. And, integrative medicine, integrative psychiatry is just good medicine, right? It's just good psychiatry. It's looking at the whole patient, as you were saying.
Exactly. Yes. I think it's interesting because both of these subspecialties, reproductive and integrative psychiatry, they almost seem like they're a little bit more novel compared to some other subspecialties in psychiatry, and yet they're so fundamental. So they're growing, I think, because people are realizing, both patients and clinicians, that these are such fundamental components.
Absolutely. And, and I think another aspect of integrative medicine that you touched on, or integrative psychiatry that you touched on, that's really important, is that it does not reject conventional psychiatry. It doesn't reject the use of medications. It's not an either or approach. It actually integrates the best of modern medicine, modern psychiatry, modern science with some of these practices that may come from ancient traditions like mindfulness and mind-body practices, acupuncture, and so forth.
Exactly. Yes. It's more inclusive. It's not exclusive. It's an inclusive type of practice.
Absolutely. And so one thing that I'm really excited to hear more about from you as well is your Integrative Reproductive Psychiatry Fellowship, which is, amazing. There isn't anything that exists like this. I believe it's the first of its kind. So I'd love to hear more about what that is. Who is it for? Can you tell us about that?
Absolutely. Yes. I'm excited about it because, like you said, it's the first of its kind. And I've done a lot of work, a lot of my own study of reproductive psychiatry. And oftentimes that focuses quite a bit on reproductive psychopharmacology and diagnosis of mental health conditions, which is super important, very, very important information to have. But one of the things that it doesn't spend a lot of time focusing on are, what are some of these non-conventional treatment options for the perinatal and postpartum populations, for example, or, those struggling with perimenopausal symptoms. And then there's the integrative psychiatry space, which focuses a lot on what we just discussed, but the patient population that tends to be excluded from a lot of the research and from a lot of the data tends to be perinatal and postpartum patients, and just more generally, women's hormonal issues. And so if you sort of picture a Venn diagram of reproductive and integrative psychiatry, that sliver in between connecting the two of them is very, very small. And I have not been able to find a kind of comprehensive course or information that synthesizes those two subspecialties. And so then, because I found myself doing this kind of research on my own and educating my own clinicians about this small sliver that connects reproductive and integrative mental health, I thought, well, wouldn't it be nice if this information could go out to all of the other reproductively focused clinicians out there who are working with this patient population, and all of those integratively focused clinicians who are working with this patient population. And that was the reason that was the impetus for my creating this fellowship, this online fellowship in reproductive and integrative psychiatry. And so what it is it's an online fellowship, which means that most of the information is asynchronous. You can do it on your own time. That's a really common question that I get from so many of the really busy clinicians who are inquiring about is, I have a full patient caseload, or I have such a busy practice. How am I going to fit something else in? So it's made to be able to do it on your own time, an hour, 2 hours a week, less or more, really just depending on individual schedules. And then there's also some collaborative and networking and live components as well that are integrated into the fellowship program. So there's a comprehensive curriculum that was created basically by taking a look at all of the different types of integrative treatments out there for perinatal, postpartum, and other kind of hormonally mediated life situations for individuals that I've worked with. So we focus a lot on nutraceuticals. We focus a lot on different kinds of interventions. We focus a lot on support systems. Sleep support is a really important one. We focus a lot on nutrition. We focus a lot on all of these different kinds of aspects. And there's both myself doing the lectures as well as some really amazing guest faculty, including yourself, which is really exciting. And so the program is structured to be asynchronous, to be done on one's own time, but then also has some of these collaborative and live components to allow for networking with like-minded clinicians. And there's also actually even a few components of business acumen included in there, because that's something else that I actually really believe in. It's something that I spend a fair amount of my time doing supervision and mentorship in, is individuals who are looking to, for example, launch their own clinic or launch their own practice. And we're never really taught the business of medicine. And so there are some of those components related embedded into the fellowship as well. We also, wanted to make sure that it's something that is going to be useful for individuals who want to use, if they have academic funds, if they need CME information. So we were able to get more than 30 CME credits in order to be able to complete this fellowship for those who need the CME component. And so I think it's going to be a really fun experience. We've had a lot of interest already. And the first cohort, which starts January 10th, is about 75% full now. I'm trying to keep it, small and contained for some of those interactive components. And I think it's just going to be a lot of fun.
Well, fantastic. I mean, this sounds amazing. Congratulations on putting this together. I know how much work must have gone into this. And I love that you're focusing on the clinical, but also the business side of practicing medicine, because that's something that most of us don't learn in, residency or in medical school, and something I wish that I had learned earlier. So I think it's great that you've included that. So who's the fellowship for? Is it for MDs only, or who's eligible to join the program?
Yeah, so really anyone who works with this particular patient population. So there is going to be MDs and DOs, there is going to be certified nurse midwives, there's going to be nurse practitioners, psychotherapists. Since we're not going to be going into the details of psychopharmacology, you can be a psychotherapist. You don't need to have a medical prescribing license to get benefit from the content of the fellowship. It's also very much focused on, actionable kinds of interventions. So I think there's a lot in, both reproductive and integrative psychiatry where, it's still very much, like we talked about, at the forefront of, novelty and research. And so there's still a lot kind of coming into the field, and not all of that is immediately clinically applicable. And so what I wanted to do in creating this is so that, you could listen to a lecture, let's say at 1 p.m., and then you go see your 2 p.m. patient, and you can use the content of what you learned with that patient that you're seeing. So it's really any clinician who is seeing patients in the reproductive lifespan. We focus a lot on perinatal, postpartum, as well as premenstrual, perimenopausal, really all of these kind of hormonal conditions across the reproductive lifespan. So any clinician that works with that particular patient population would be able to benefit from this fellowship.
Excellent. And I love the fact that it's really practical and applicable to your patient care, because that's really the type of education we need if you're working with patients. So let's talk a little bit about sleep. So I'm really, honored and delighted to be speaking about sleep in the fellowship program. And, I'm interested in women's sleep health. It really is an underserved area when it comes to sleep research and even just clinical sleep medicine. So let's talk a little bit about that and some of the changes that we see in sleep across the lifespan in men and women, but especially in women. So could you share a little bit about how sleep changes across the lifespan?
Absolutely. So sleep changes quite a bit with some of these various hormonal shifts that take place during a woman's reproductive lifespan. So for example, in pregnancy, about 80% of women report disturbed sleep. 80%. That's the vast majority of individuals who are pregnant. And it could be any number of different kinds of sleep disturbances. It could be insomnia. It could be, more challenges with early morning awakening. It's a lot of interruptions because of physical and other kinds of discomfort. But there's 80% of women are describing disturbed sleep in pregnancy. We also know that sleep is quite a bit disturbed postpartum for some of the obvious reasons, including having a newborn, but also some of the perhaps less obvious reasons, which is the fluctuating hormonal changes that take place. And then sleep disturbance is a really significant component leading to mental health symptoms and also other kinds of issues in the perimenopausal transition. There's actually more and more research being done on that. But to your point, these are underserved populations in the research world. So even if you look at some of the most common sleep conditions, let's say sleep apnea has been studied so well in men, and we have a lot of treatment options. one thing that we don't think about is one of the most common times when sleep apnea is diagnosed is actually during pregnancy, because that can, the rates of sleep apnea and other sleep-related conditions like restless legs significantly increase in pregnancy. And, what are the treatment options for that? What is sleep like during the perimenopausal period? I think there's often this kind of acceptance that, oh, of course you're not going to be sleeping because you have these night sweats and you have to go through this and it has to be uncomfortable. So there's sort of this acceptance of the fact that it's going to be hard and you just kind of have to go through it. And I don't think that that's something we need to be just accepting. I think it's something that we need to address from the perspective of sleep and the hormonal changes and all of the other changes that are taking place at that time.
Definitely. And it's really important to recognize some of those conditions that you just listed, because what I see a lot with female patients is that they'll get diagnosed as having insomnia because they don't sleep well, when there actually might be undiagnosed obstructive sleep apnea or undiagnosed restless leg syndrome or another sleep disorder that could be causing sleep disruption. And so I think it is really important that anyone listening recognizes that with their patients, especially during pregnancy, there is that increased risk of restless leg syndrome and obstructive sleep apnea. And also after menopause, we see rates of obstructive sleep apnea increase significantly after menopause because of changes in hormones affecting the airway and collapsibility of the airway. And sleep apnea can show up very differently in women than it does in men. So along those lines, what kinds of sleep issues do you see with your patients practically in your clinic?
One of the most common things is really sleep issues induced by other kinds of mental health conditions. So one of the cardinal symptoms of anxiety is a disturbance in sleep. One of the cardinal symptoms of depression is a disturbance in sleep. And so the relationship between those different conditions, the helpful thing is that we can often, it goes in both directions. If you're having trouble sleeping, it's probably going to make your mood worse. I mean, that happens to all of us. We don't sleep, and then the next day we're cranky and irritable, right? And so it goes in that direction. And then it goes also in the other direction where symptoms, for example, of depression are going to include changes in the sleep cycle and the sleep architecture. And often it could be early morning awakening. And there's all different kinds of sleep changes that can happen with some of these mental health conditions. And so what I usually see in my clinic is a combination of either anxiety plus sleep issues or depression plus sleep issues or some other kind of mental health condition plus sleep issues, bipolar disorder, whatever it might be. Even, for example, individuals struggling, let's say, with substance use, that's, alcohol impacts our sleep architecture and the way that we sleep. So all of these different kinds of mental health syndromes have a sleep component, and that's often the way that I see it in my clinic.
Absolutely. And so there is that bidirectional relationship as you were describing. So what are some of your approaches, whether it's from conventional psychiatry or integrative medicine? How do you help these patients?
Yeah, so one of the first things is to actually figure out what's going on accurately, right? Like you said, it's not just stamping a label of insomnia and moving on from there and, throwing a sleep aid into the mix, which certainly there's plenty of really helpful sleep aids, but let's first figure out actually what's going on. Is it insomnia? Is it anxiety? Is it depression? Is it sleep apnea? I mean, what is happening? So let's figure out what's happening first and think about, do we want to intervene? On which level do we want to intervene? Do we want to consider, addressing some of these anxiety issues? And then from that place, we'll see that the sleep issues get better as well. What direction do we want to potentially make our intervention? So let's figure out what's happening first. The other thing that I often really talk with so many of my patients about are two cardinal components of treating sleep issues. One is focusing on sleep hygiene and routine, and the other is CBTI, cognitive behavioral therapy for insomnia. And I love CBTI. It's gold standard treatment option for so many different kinds of sleep conditions. And it's been studied across the reproductive cycle. So there's some really good data on, for example, CBTI treating and everything from depression to vasomotor symptoms to sleep disturbance in the context of perimenopause. And there's all kinds of data on the impact of CBTI for all of these different kinds of hormonally mediated sleep disturbances. And then really sleep hygiene is so important. And I think a lot of us know what it is, and we still often don't actually do it. I know I'm guilty myself of, waking up at 3 a.m. and checking my phone, as opposed to, recognizing that that's actually going to do the opposite of what I need to be doing at 3 o'clock in the morning. And so I think a lot of us kind of know what we quote unquote should be doing, even though I don't like the word should, but we oftentimes don't do it. And so part of the process is figuring out, okay, what's the lowest hanging fruit? How can we begin to kind of build these habits in a way that isn't going to be completely overhauling our entire routine, but really is going to build good habits, good sleep-related hygiene habits over time to help our sleep.
That's a great reminder, because these lifestyle and behavioral interventions have a huge impact on our sleep quality, right? Like oftentimes people will be looking for, what supplement should I take or what medication should I take, when sleep hygiene is all over the board, right? So just kind of implementing these structures and these routines can have a significant impact, even modulating light and dark exposure.
Mm-hmm.
I'm seeing so many patients with light deficiency during the day and then a darkness deficiency at night. And so it throws their circadian rhythm out of whack. And another thing that you mentioned, I think that's a good distinction, is that sleep hygiene is not the same as CBTI, or cognitive behavioral therapy for insomnia. These are two different things. Sleep hygiene can be a part of CBTI, but CBTI is a whole thing in and of itself. And so for any therapists or doctors who are listening, what are some simple CBTI principles that they might be able to share with your patients, or what have you found to be most effective that you want people to know about?
Absolutely. So certainly the sleep hygiene component is a component of CBTI, but a lot of the other concepts really focus on the psychology behind sleep as well. And so what often ends up happening, this is something that I talk with a lot of my patients about, is that there can be a lot of sleep anxiety. And that's something that CBTI really works to address, is kind of this anxiety about sleep. So when individuals have had a number of nights of poor sleep, they sort of begin to develop this catastrophic type of thinking about what the next night is going to be and what the implications of that is going to be on their day and their functioning. And so these pathways are created, these psychological pathways are created between anxiety and sleep becomes this mountain that is almost insurmountable for individuals. So a lot of the work of the cognitive behavioral therapy for insomnia focuses on those kinds of psychological pathways and breaking them down and creating different set of psychological pathways. So one of the most common examples that I talk with my patients about is the role of that anxious countdown that sometimes happens, where you look at your clock and then you count, I only have 5 hours left. I only have 4 hours left. I only have 3 hours left. And it creates kind of this sense of panic. And so what can we do about that? I have, one patient who's really religious about never checking the clock when she wakes up in the middle of the night. And I think that's a really helpful small thing. I mean, you just turn the clock around and you don't check it. So that can sometimes be one step to help with some of that sleep related anxiety. And that's one of the ways that CBTI works, is that it works on that psychological component.
Right, absolutely. And it works on those components that are perpetuating the cycle of bad sleep, or, insufficient or disrupted sleep.
Yes.
And another thing that is, I think, helpful for people to know when it comes to sleep is that, we were talking about changes across the lifespan, but there's also changes for women across the menstrual cycle. And so, sleep naturally fluctuates. Could you speak a little bit about that and how sleep kind of fluctuates at different times of the month?
Yeah, so that's, we think about hormonal changes across the lifespan, but they are happening on a monthly basis. And sleep can be significantly disturbed for women depending on where they are in their menstrual cycle. Oftentimes, women report worse sleep during that luteal phase, which is the phase between ovulation and menstruation. And that's often the time when women might also report an uptick in symptoms of anxiety or irritability or depression or physical discomfort. And that is the time when sleep also tends to be disturbed. And it makes sense from the perspective what's happening with the hormones in terms of the ratio of estrogen and progesterone. That is most likely the culprit for these kinds of sleep disturbances. And for some women, it can be happening on a monthly basis.
That's really, really helpful to know. And something that I see with women, especially during that luteal phase, is that they also have increased daytime sleepiness. And so, some of the habits that we might recommend when it comes to sleep hygiene can change at different times of the month. And so for anyone listening, again, clinicians or just sort of anyone who's interested, is to recognize that your habits can change according to the seasons, according to the different times of the month. And you don't have to be so rigid with sleep, because it is that rigidity that can also feed into this perpetuating cycle of insomnia.
Absolutely. And I think that also comes from this place of, recognizing some self-compassion and the fact that at different times, whether it's of the month or various stages of your life, you might need something different, and just kind of accepting that your body, your mind, your hormones, however you want to think about it, might need something a little bit different, and to accept that and treat yourself with some compassion and offer yourself whatever you might need at any given moment.
So you've shared so much great information just in our brief discussion so far. So what are some other kinds of things that people can expect to learn during the fellowship?
So we focus a lot on perinatal mood and anxiety disorders and treatment options for, pregnancy and postpartum related mental health issues. So for example, the first module, we focus a lot on nutraceuticals for anxiety, nutraceuticals for depression, nutraceuticals for sleep. We focus on attention and cognition issues and premenstrual and perimenopausal botanical options. So module 1 focuses a lot on nutraceuticals and botanicals. Module 2 focuses a lot on various kinds of interventions and devices. So we have lectures on ecotherapy, on acupuncture, on physical activity, on pelvic floor physical therapy, a lot of different kinds of interventions that are really helpful and are part of that integrative psychiatry space. Module 3 focuses a lot on nutrition. So we focus on anti-inflammatory diet and the data on that, and mental health. We focus on the role of emotional eating and body image. Module 4 focuses a lot on support. So things like sleep support, lactation support, other kinds of support systems. And module 5 focuses a lot on, integrating some of the conventional options with some of the non-conventional options. So we have lectures on, for example, ketamine and TMS and how that can integrate with a comprehensive treatment plan. And then we also have some additional lectures on special populations. We have a really great guest lecturer who's talking about Black maternal mental health. We have a great lecturer who's talking about cannabis use in pregnancy and the data that we have on that. So we've tried to be as comprehensive as possible in putting together something that's going to be really up-to-date, evidence-based, but also immediately applicable in the clinical world.
Well, this sounds amazing. And so for anyone who's interested in learning more, where can they find more information about the program?
So the fellowship is available. If you go to psychiatryfellowship.com, you'll be able to see much more comprehensively all of the different benefits, the full curriculum, and certainly feel free to use the contact form, and I'm happy to answer any questions.
Great. And I'll put the link as well in the video description under this video.
Perfect. Thank you.
So, well, thanks, Dr. Glezer, for joining me today. This was really informative. And I really appreciate you taking the time.
Thank you so much for having me. I've really enjoyed it.